Good afternoon, everyone. My name is Deirdre Roach, and on behalf of the Interagency Work Group on Drinking and Drug Use in Women and Girls, I'm pleased to welcome you to today's webinar, An Introduction to Online Research Strategies, Recruitment, Management, and Intervention. This webinar is designed for investigators interested in moving some or all of their research programs online as a result of the COVID-19 pandemic. Although it's designed to be broad enough to apply to behavioral research broadly, many examples will be taken from alcohol use research, particularly with women. There will be time for questions at the end. This webinar is being recorded and we'll publish the link to the recording as soon as it becomes available. To maximize the quality of the recording, you have been placed on mute, so we ask that you use the chat box to submit your questions. We also ask that you turn off your video to improve the quality of the recording. First, we'll hear from Dr. Karen Ingersoll. Dr. Ingersoll is a clinical health psychologist and professor of psychiatry and neurobehavioral sciences at the University of Virginia's School of Medicine. As a clinical researcher, she develops and tests interventions using motivational interviewing and technology delivery to improve the health of people living with HIV, reduce the risk of alcohol-exposed pregnancies, and encourage lifestyle changes to promote health across the lifespan. In today's webinar, Dr. Ingersoll will share her experience conducting a recent trial involving online recruitment and an internet intervention designed to reduce alcohol-exposed pregnancies. Next, we'll hear from Dr. Jamie Heffner. Dr. Heffner is an assistant member in the Cancer Prevention Program, Division of Public Health Sciences at Fred Hutchinson Cancer Research Center. There she serves as the director of the Tobacco-Related Health Disparities Research Group. Dr. Heffner's primary research focus is tobacco cessation interventions, with an emphasis on assisting tobacco users with co-occurring mental health conditions and substance use disorders to quit. This afternoon, Dr. Heffner will share lessons learned from 9 studies involving online recruitment and app-based interventions, highlighting current optimized strategies for high-reach online recruitment through social media, particularly via Facebook and Instagram. Finally, we'll hear from Dr. Stephen Ondersma. Dr. Ondersma is Deputy Director of the Merrill Palmer Skillman Institute and professor in the Department of Psychiatry and Behavioral Neurosciences at Wayne State University. His primary interest is in population-level interventions promoting maternal and child health in underserved communities, particularly via technology-based brief interventions for substance use in the perinatal period. Today, Dr. Ondersma will review common types of online interventions as well as options for their development, particularly in cases where large budgets for software development are not available. Issues regarding the validity of online samples, consent, and participant protection will also be addressed. To open our program, please welcome Dr. Ingersoll.
Hello, everybody. Thanks for being here today. I'm glad to be able to share about our CARRY study, which was an online intervention for alcohol-exposed pregnancy risk reduction. And I'm going to try to focus my comments today not only on the intervention, but also on recruitment and impact. Next slide. So why intervene on alcohol-exposed pregnancy risk? I'll address this first. I'll then talk about the different intervention components and how we made the intervention engaging for women at risk. We'll also talk about efficient recruitment for an online intervention and share the pilot efficacy findings from the intervention trial. Next slide. So the reason we tackled this problem is that, unfortunately, alcohol-exposed pregnancy risk is surprisingly common. The most recent data out of CDC showed that about 1 in 30 women in the US of childbearing age 18 to 44 are at risk of an AEP in the past 30 days. And that's because of regular high levels of drinking or binge drinking that exceed NIAAA guidelines, paired with either ineffective, intermittent, or incorrect contraception, and frankly, sometimes no contraception at all. Next slide. But this really does give us a challenge and an opportunity. So there are many, many women at risk of an alcohol-exposed pregnancy, but most of them have no access to a trained counselor who's familiar with evidence-based counseling interventions for alcohol-exposed pregnancy. The opportunity, though, is most women nowadays have access to the internet, either through a mobile device or a computer or a tablet. Next slide. And I wanted to describe briefly what an e-health intervention is. This is an online intervention, and it usually transforms evidence-based face-to-face behavioral interventions for web delivery. The advantage of a web-based browsing kind of intervention is that really the data plan requirements are not very large. This on a phone, for example, they can access it without using a ton of their data. And I want to be clear that these kinds of interventions are not static websites like WebMD or something like that, where you're just going to look up information almost in a book format. But instead, these host automated and prompted assessment, information provided via multimedia, so you can use video and audio and interactive elements that can be cartoon-like or real life. And very importantly, to mimic counseling interventions, there's a lot of personalization to the user based on the user's input into the program. Most of these interventions contain engaging interactivity, and these really encourage users to explore alternatives and make choices and decisions similar to what they would do if they were receiving face-to-face counseling. And in our lab, we've typically used a process of weekly metering. And what happens is people complete a certain amount of content and then they wait a week during which they do some self-monitoring between sessions of the targeted behaviors. Next slide. So this intervention was called CARI, and that stands for Contraception and Alcohol Risk Reduction Internet Intervention. And CARI was based on two sources of information and content. The first was the most robust to date alcohol-exposed pregnancy risk reduction intervention, which was called CHOICES. And CHOICES was tested in a very large efficacy trial with over 800 women. We found in CHOICES many years back is that the rate of alcohol-exposed pregnancy risk dropped from 100% to 34%. And our secondary analyses were very interesting because they proved that not only the motivational interviewing counseling style that we used in this intervention, but also the specific interactivities with the counselor led to positive changes in drinking and contraception behaviors. Now, CHOICES had 4 sessions of MI plus feedback for women at risk, and it's been disseminated by the CDC. You can see the manual for counselors that they've distributed there on the left. We took that as our basis to develop CARI, and we mocked up what we thought might be useful to show women in originally paper form and then finally in some interactive forms. And we did a bunch of usability testing, focus groups, interviews with women who are at risk of AEP or who had risks consistent with that group. And fortunately, over time, as we iterated on this, women gave us positive feedback. They really liked that they learned from the program, and also they liked the tone. So we felt like we'd hit the mark in terms of the motivational interviewing counseling style. And we used all of the women's feedback from usability trials and think alouds and interviews to complete the program. Next slide, please. This is a screenshot of the home page of Carrie, and it's just the landing page that a user would come to when she logs in. Next slide, please. And we tried to build in the motivational interviewing communication style across the program. So the program is built into 6 cores. So we transformed the 4 choices sessions into 6 cores of information, sort of like chapters in a book, but very interactive. Each core begins with a review of her past week's diary to take advantage of the self-monitoring. And the program elicits her reactions and response with preset reflections, feedback, and summaries. She gets affirmations for completing various steps of the program, and there are even open questions that we ask throughout the program, and users either select some of the possible answers we pre-programmed or can fill in an open field. So her responses are then gathered and summarized back to her at various stages throughout every core. Next slide, please. This is a picture of the core landing page, and you can see we had the 6 cores laid out. There's an overview core, your risk of alcohol-exposed pregnancy core, contraception, drinking, thoughts and decisions, and the last core called commit to it. Next slide, please. We also built in a lot of personalized feedback throughout Carrie because personalized feedback for drinking especially has been found to be very useful. So it's not only embedded in interactions that are within each core, but it's also a way to provide explanations about drinking, pregnancy, and AEP risks that are really tailored to each person. Personalized feedback is also provided in response to diaries and charting that are done throughout the program. And personalized feedback provides some tools to guide goal setting. Additionally, change planning ideas and guidance are provided and then tailored based on what she enters. And the last element for personalized feedback that was actually very popular is we allowed women to print out a certificate of completion at the end of the program, and we got a lot of feedback that they really liked this. Next slide, please. This is an example of how we collected the online diaries. So in between cores, users have a week to complete diaries. And you can see here in the calendar view, you can pick any particular day that's not already completed. Those are shown with the red dot. If you click on a day, it opens up the daily diary and you complete data on your drinking, your sexual behavior, your contraception use, and quality for that episode. And you can see on the left-hand side of the calendar view, there are little icons that look like graphs. And if the user clicks there, she can see graphical feedback of her last entries at a week at a time. So there's a lot of opportunity for her to learn from her data entry and from her behavior. Next slide. Now I'm going to turn to the process of recruitment. Our target in Carrie was to take 6 months to recruit 75 women at risk of alcohol-exposed pregnancy. And you might expect that recruiting women would be easy, but actually women at risk of an alcohol-exposed pregnancy are kind of a hidden group. They don't really identify with any particular interest groups that you might find on some of the online platforms. And so we had to be creative. And another challenge was because we're at the University of Virginia, we have these very ugly, I would say even hideous, allowable research advertisements that we had to use. And so we posted these on the various sources online as well as in posted flyers. We posted on Facebook, Twitter, Craigslist, the UVA research site, and clinicaltrials.gov. And the way we decided to post for Craigslist, some of you may know Craigslist is organized by city. And so we actually use BRFSS data from 2011 on drinking, women's drinking patterns, and picked the cities with the highest rates of binge drinking. And you see some of those listed here. Next slide, please. Now this is a map of our recruitment, and this shows the applicants over participants. And you'll see we recruited in the end from January through August 2015. So we actually hit our target in terms of the number of women recruited. It took us one additional month than we were expecting. And we also over-recruited from the cities that we had targeted, as well as within our own state of Virginia. So Virginia, Pennsylvania, Massachusetts, Wisconsin, and Michigan contributed to the most applicants, followed by California and New York. Next slide, please. So of the 947 applicants that we had for the study, we assessed how they learned of the study. 828 learned online, 84 learned by word of mouth, 35 learned from flyers. And on the bottom there, I've got the yield. Craigslist ads yielded the majority of applicants. And the next largest pile came from seen elsewhere on the internet, which was really word of mouth or psychology department, followed by Facebook. But the yield, how many ads, applicants divided by the ads posted on that format, was actually highest for seen elsewhere on the internet, followed by Facebook, followed by Craigslist. Next slide, please. So the Siri's talking to me. The CARRY study involved enrollment and eligibility assessment, then randomization. CARRY participants were allocated either to the CARRY intervention or to patient education, which was sort of a boring, static website that looked similar to WebMD, but contained accurate information about alcohol-exposed pregnancy risk and how to reduce it. We had a 9-week or post-treatment follow-up and a 6-month follow-up and then an analysis period. And we had quite good retention over time. Next slide, please. These are the results from the CARRY study. So on the upper left, you see the rate of alcohol-exposed pregnancy risk, which was reduced in CARRY from, everyone was at risk at screening. Some women already started making changes in the first pre-treatment online diaries. The second set of online diaries was post-treatment, and then we did another set at 6-month follow-up. So you can see that compared to patient ed, CARRY was significantly lower in terms of both alcohol-exposed pregnancy risk and unprotected sex risk. Also at the post-treatment period for binge drinking, but that popped back up for both CARRY and patient ed. And so that was no longer significant at 6 months. Next slide, please. So there's a couple takeaways from my project. First, online recruitment, especially focusing on free Craigslist ads, can be efficient and inexpensive. We published a paper on this. CARRY was the first fully interactive and automated internet-delivered alcohol-exposed pregnancy risk reduction intervention. And very promisingly, over 70% of women completed all 6 cores. And we think this shows acceptability and relevance to our population. Just as importantly, though, is the impact. CARRY really is very similar to the results of the most robust face-to-face counseling intervention choices in terms of its impact. Now, some women still remained at risk of alcohol-exposed pregnancy, mainly due to heavy drinking. Next slide, please. So we think that CARRY could be scaled up to reach many more of the 1 in 30 women at risk for alcohol-exposed pregnancy every month. And next slide. Our plans are to update CARRY to be usable on any device. So even though we didn't really design it for mobile delivery, a lot of people used it on their mobile phone. We'd like to test it in a larger, more diverse sample, really focusing on higher risk drinkers, and identify those subgroups who might need added intervention to achieve that reduced drinking risk. Next slide. Thank you very much, and I'll take questions at the end after everybody else has spoken.
Okay, well, I'll go ahead and jump right in the interest of time and move on to the next slide, please. So I think it goes without saying that research recruitment can be difficult, and it's particularly difficult when we're trying to recruit populations that are marginalized. And that's where a lot of my research focuses. So one tool that we've found to be very effective in reaching these groups is Facebook ads. So today I'm going to talk about what I see as being some of the key benefits and challenges of using Facebook ads for study recruitment. I'll also go over some of the basics of how to set up and monitor a Facebook ad campaign. And most of what I'll talk about will be how to recruit people on Facebook and not what happens once you bring them off of Facebook and onto your web-based screener. But I will touch on that a bit at the end, as it's pretty important in online research to think about a plan for preventing fraud. Next slide, please. Okay, so why might you consider using Facebook to recruit research participants? One reason is that out of all of the social media platforms, Facebook has the best combination of reach and engagement. So if we look just in the US, that first figure on the left there shows that with the exception of YouTube, Facebook reaches by far the largest proportion of adults. And then on the right, what you see is the level of engagement with all of those platforms. So the Facebook platform, almost 75% of the users are engaging on at least a daily basis. So most adults in the US are on Facebook, and most of them are on Facebook daily. And if you look even beyond the US, Facebook has over 2 billion users monthly globally. So it's just an incredibly high reach platform. Next slide, please. Another reason that you might consider using Facebook is that it has pretty powerful ad targeting capabilities. And that includes basic things like age and gender and where someone lives. You can also do some targeting that's specific to user interests and behaviors. And that's where you can put in some characteristics that would help you find people who are likely to be using substances. It's also a good tool to help reach hard to reach populations like marginalized groups or people with rare conditions. Next slide, please. My experience with Facebook ad recruitment has largely been in the area of tobacco cessation trials. And there, when we're recruiting just general population samples, we get recruitment rates of about 78 to 146 randomized per month. And that's even with ads not running on a daily basis. So often we have to turn the ads off for a period of time so that there's a bit of a bottleneck in terms of staff's ability to follow up on things, either that screening or following up people later after treatment. So we have to sort of pace the recruitment. So I've never, I don't think, actually capped out the potential for Facebook recruitment levels. I also just started consulting with a group who's recruiting people through Facebook for a study of adults with an alcohol use disorder. So I'm helping them get their Facebook ad campaign up and running. And within 12 to 14 days of running Facebook ads, they had 650 surveys completed. Next slide, please. In addition to being efficient time-wise, Facebook can also be a very cost-effective way to recruit. So there have been a few systematic reviews on this topic of recruiting via Facebook for various health conditions and health behaviors. And the median cost per enrolled participant in those reviews has been in the $12 to $14 range, which compares really favorably to other types of recruitment methods. It's pretty consistent with what we see in the tobacco cessation trials. Although I will say we did a study recently where the cost per enrollee was $3, which was very efficient. One thing to keep in mind, though, is as your eligibility criteria become more and more narrow, you're going to have a higher cost. Next slide, please. Okay, so let me talk about a couple of the big challenges when we're using the Facebook ad platform. One of the big ones is privacy. So, like all social media sites, Facebook is not really designed to promote the privacy of users. So, it's designed to promote interaction and to get people to share personal information, in fact. It's the opposite. So, when you place an ad on Facebook, people may interact with that ad in a way that risks their own privacy or someone else's privacy. So, for example, um, when an ad is placed, people can tag their friends in the ad, which, if you're not familiar with that term tagging, it's basically somebody's name will appear in a comment field below the ad, and that person who's named there will be alerted that their friend tagged them. So basically, it's like the equivalent of someone, the Facebook equivalent of someone screaming across a crowded room, "Hey, Karen Ingersoll, I think you might be interested in this study for people who drink heavily." We have to be careful when we're doing research with stigmatized groups or behaviors that we're not setting people up to be outed in that way, um, or that we have procedures in place to monitor that and respond quickly. Another question is related to privacy. When you put an ad there, you are generating data for Facebook that they can use for unknown and uncontrollable purposes. So this is Facebook's business model. They harvest user data and sell it to advertisers. So we just, as researchers, don't have a lot of control over what's happening on the Facebook end. So aside from hiding tagged posts, which I already mentioned, a couple things that you can do to help protect people's privacy. One is perhaps not disclosing the full purpose of the study on Facebook. And another example would be not actually collecting any user data on Facebook itself, rather bringing them over to a separate website for screening, and then not allowing Facebook any access to that other site by placing any Facebook code on it so you can track people. Next slide, please. Okay, so another big challenge is that if you leave these social media ads up long enough, they're bound to attract one or more bad actors like trolls or spammers or scammers. And because these sites are designed for interaction, you can't actually proactively prevent this. So you can't turn ad comments off. You have to be prepared to respond to them. So when we have ads running for studies, we're usually monitoring them on at least a daily basis. And if it's a stigmatized group or behavior, probably more like an hourly or every other hour basis to make sure that we're not getting these kinds of comments. Next slide, please. Okay, so there are two ways to target on Facebook. One is what you do on the front end, and that's what the users will see when they go into the platform. So here are some examples of ads from a couple of our recent studies. So this might be similar to what you would do for a flyer that you might just post around somewhere, something that you might be more familiar with, but with some important exceptions. So the structure of the ad here is at the top you have the source of the ad, and we always post our ads through our institutional account. And the reason for that is that people recognize the name, so it has some credibility and they know what they're clicking on, that it's a trusted source. The part that will attract attention from people is the image that appears in the ad. So we typically use brightly colored images that clearly show the purpose, what we're trying to communicate to people. We typically use still photos for this, although you can use video or carousels. And then above that image is a very brief description of the study. So this is just basically one or two sentences to explain what the study is about. Underneath the image is a few brief text fields. And then in the bottom right is a call to action button, which here is a learn more button. And when people touch or click on that, it takes them to whatever website you want to take them to. So for research purposes, this would typically be a recruitment web page or a screening site. And I should also mention that there are a lot of different formats for ads depending on where they appear on Facebook or Instagram. So this is just one example of a format for an ad. Next slide, please. The other place that you can target is on the back end. So this is where advertisers choose their audience that they want to show the ads to. And here again, you can target on things like demographics. So I want people in a certain age range. I only want people who identify as women. I want people within a 10-mile radius of Seattle or all of Washington State to see these ads. And then where it gets interesting is where you can start targeting to people's interest or the type of content that they engage with on Facebook. So let's say we're doing a study where we're trying to recruit people who have current or past alcohol use disorders. So we might segment that group into people who are current users, current heavy drinkers, people who are in treatment or recovery. We have slightly different interests for those two groups. So for people who are heavy drinkers, I might enter interests like alcohol or drinking establishments or behaviors that we know go along with heavy drinking, like smoking or gambling or marijuana use. If I'm looking at people who are in treatment or recovery, some of those same interests might apply, but we might also have some treatment or recovery related interests as well, like the Big Book or Smart Recovery or Women for Sobriety. These are actually targeted keywords that appear in the Facebook platform, and you're welcome to borrow from these if they're helpful. Next slide, please. Okay, so one of my favorite parts about the Facebook ad platform is that it lets you do an empirical test of how well your ads are performing. So these are metrics from one of our ad sets. And so what we do is before the campaign, you just prepare a whole bunch of different options for ads using different images, different words, maybe different targeting parameters. And then you would take a look at these ad performance metrics after you've let them run for a couple of days. And what you see here, the column labeled impressions is the number of times an ad has been shown. The reach is the number of people, unique people that have seen it or it's been shown to. And the results are the number of people that clicked on that link, that call to action button. If you look at the cost per result, that is you'll notice there's a relationship between cost per result, which is a cost per link click, and the success of the ad. And that's by design. So Facebook rewards more engaging content with it being less expensive. So when you're monitoring an ongoing ad campaign, you're going to want to keep checking back on these metrics because the ads at the bottom, you're not getting very many results from them and they're costing more. So you'll want to turn off the ads that aren't performing as well and just keep the best performers running. Next slide, please. Okay, another thing to know about the ad platform is that you can place ads on a variety of different places within Facebook and even outside of Facebook. So Facebook owns Instagram and Messenger, so you can put things on the main Facebook feed, Instagram and Messenger through this platform. You can also put it on outside of Facebook through this option called Audience Network. So for this particular campaign, we chose to show ads only on Facebook and Instagram. And what this is showing is that we reached more people on Instagram. That's the blue bar on the left. But Facebook had a higher number of link clicks, which is the green bars on the right. So Facebook actually ended up being more effective for this particular campaign than Instagram, which was surprising because this was young adults and I expected just the opposite. Next slide, please. Okay, so now after you have identified some potential participants on Facebook and brought them over to your online screening, what are some ways that you can help to prevent fraudulent study entry? So we usually use a combination of methods because there really isn't just one foolproof method, and even a combination of methods is not foolproof. But we use initially a CAPTCHA authentication to even get into the screening survey. So that's the example that you see there on the right. It's the squiggly numbers and letters that you have to retype. And that's really good for only detecting whether it's a human or a bot. And then once people have completed the screening survey, we'll do things like reviewing IP addresses. And so we can see, are there any duplicates in there, which may indicate that somebody's repeating the survey more than once? Are the IP addresses within our catchment area that we're trying to recruit from? So if we're doing US only and we see IP addresses that are registered outside of the US, that's a red flag. We can look for things like completing the surveys too fast. So if you know a reasonable person would take about 20 minutes to complete something and you have completion times that are less than 5 minutes, that's a red flag. Also, if they're odd or patterned responses in the email addresses, like 10 addresses in a row that are from yahoo.com. Also, particularly concerning if those all come in within minutes of each other. So that might be a flag. And then when we have flags, that doesn't necessarily mean that it is fraud, but it's just something to follow up on. So we can do some sort of follow-up procedure, which is typically by phone, to try to confirm the information. And if we can't confirm it, then we consider them not eligible to participate. Next slide, please. Okay, so it's hard to do justice to the topic of Facebook recruitment in just a short time. So I've included here some references that you can take a look at if you're interested in learning more. It's pretty rare that people describe recruitment procedures in great detail in journal articles, but the 3 articles here did do that, and sometimes even included things like screenshots of the ads that they used and talked about success of their campaign, what worked and didn't. So those may be helpful references. One thing to keep in mind, though, is that Facebook ad policies and procedures change really dramatically, sometimes overnight. And so something that was published even a year ago may already have some dated information in it. So I included the Facebook advertising guide link at the bottom here, which is the most up-to-date you can get, and that's in the business help section on Facebook for Business. Slide, please. Okay, thank you, and I'll turn it over to Steve now.
Thanks very much, Jamie. I'll dive right in as well so that we can have some time for questions. Delighted to be able to talk with all of you. I'll be focusing on the intervention piece here, and I'll be talking to kind of a very particular case, and that is folks who are having to convert a study that used to be face-to-face into an online study involving some sort of intervention. People in that situation are finding themselves having to do a lot of conversion very quickly and don't necessarily have a big tech budget or a lot of tech expertise on board. So I'm going to do a very fast overview that I hope will be helpful for people in that situation. In doing that, I'll be touching just generally on some basic steps that you could take to try to address that and maybe move forward with your research. Next slide, please. Before I begin, I need to say that I am part owner of a company that licenses e-intervention authoring software to other investigators. Need to put an asterisk by this, though. I'll return to that in a little bit. Next slide, please. So in terms of overview, I'm going to talk briefly about what an app is. There are actually multiple kinds, and those distinctions are very important in trying to figure out what's going to work best for you in your particular study. Secondly, I'll talk about some different options that you have for developing an app, especially on the cheap. And then third, I'll talk about just some general tips and tricks that have helped me along the way in developing my interventions. I typically do, as Dr. Roche said at the beginning, I typically do interventions for women in pregnancy or postpartum periods around substance use. I won't be sharing any of the data of those studies. I'm only going to be talking about the nuts and bolts of building an intervention. Next slide. So first, what's an app and what do they look like? Next slide, please. Thank you. So there are actually 4 kinds. Usually what you think of when you say, I downloaded an app, I want to make an app, is there an app for that? You're thinking of a native app. That's something that was programmed specifically for use on a particular platform, usually either Android or the Apple iOS platform. It resides on that particular device. It works offline. It usually looks really nice. It's stable, has a lot of advantages. And that was really the only way to access all of the features of the phone, all the sensors, the camera, the GPS, anything that you would want to be able to make your intervention as well-rounded as possible. So plenty of advantages. Unfortunately, it's also the most expensive way to go. It's tough to modify and people have to update it manually. So you have an intervention out there that isn't the same for everybody at the same time. People will be walking around with different versions. And then also, finally, you have to get approval from Apple or Google to post it on their app store and make it available to people. You have to have a developer account, so there are some steps to go through before you can make it available. In contrast, a mobile web app is nothing more than a fancy website that works in the browser of that particular device. So it's automatically available on any platform, whether it's Android or Apple or a PC or Mac. Used to be that a mobile web app could only have a couple little features that it couldn't do nearly as much as a native app. And that gap has closed quite a bit. It's now possible with a mobile web app to access a lot of the features of mobile devices. So overall, this type of an app is cheaper to develop, cheaper to maintain, easier to update, and everybody always automatically has the most updated version. And you also don't have to submit it through an app store. You just post it and you're done. Third type is called a hybrid app. This is an app that resides on an app store like the Apple App Store, the Google Play Store. It gets downloaded onto the home screen of that device, but instead of having everything there to run completely offline, it makes heavy use of the internet to bring in a lot of the features and a lot of the content. So that way you're sort of in a way getting the best of both worlds. You have something that's stable and shows up full screen, and has some of the features of a native app, but at the same time it's easier to update and a little cheaper to build. Has some downsides too. It can be slower, and you still have to submit your that hybrid app, the native piece, to the respective app stores. And then finally, most people haven't heard of progressive web apps in our business. They're the newest kid on the block. They're not all that new, but they're getting a lot more attention lately. A number of groups are moving towards progressive web apps as a complete alternative to native apps. It's essentially a native app that lives inside of a website. So people can access your app directly. You don't have to submit it through a store. And if they choose to add it to the home screen, it can then work offline. It can then show up full screen, and it can access all of the features of that phone in terms of GPS, camera, etc. So they're a really neat alternative, and they're very powerful and something to consider. Next slide, please. But in thinking about which way to go, I just want to make sure that you have as a framework what a typical native app might cost. This is a website from a reputable developer in my area. Next slide, please. As you'll see, just a very basic app that works on one platform, only Apple or Google or Android, will cost about $30,000 to $100,000 just for kind of a pilot proof of concept sort of app. Next slide, please. To get something with a lot of features and some nice bells and whistles that works on both platforms, so you have a native app at each of the different app stores, we're talking about $250,000 to $500,000 or so. And this is fairly consistent with my experience with other developers as well. Next slide, please. So it's because of that if you're thinking about going in this direction, whether immediately or long term, I really encourage you to think about mobile web apps as a starting point. That doesn't mean that that's the only place you ever go. That means that just the way that we might do a pilot study before we do a fully powered confirmatory trial, a mobile web app might be a really good way to go initially. And then once you really think you've got it nailed down and it's stable and you're not going to be making a lot of changes and you want to make it available in a different way, that might be the time to go to a native app or to a hybrid app. And actually, or a progressive web app actually as well. There really should be 3 arrows there. Next slide, please. But how do you go about getting one of these? What are your options for building it if you're in a position where you don't have a lot of time and you don't have that big budget to make a really nice native app? Next slide. So I'll talk about some ways that you have the power to make something that, in my opinion, is awfully darn good without having to go that route. Obviously, this is an entire separate field. There are disciplines dedicated to making M-health and e-health interventions. There are entire conferences and journals dedicated to it. It's not something that anybody can just sort of rip off at a moment's notice. But at the same time, I think you can get pretty darn far when you need to using some alternative approaches. And so I'm thinking in terms of saving a study that otherwise might be in real trouble because of COVID-19. One of the things to think about, I'll talk about three major options right now. One of the things to think about is Qualtrics and REDCap. You're already familiar with them. You probably have access to one or both of them for free. They're incredibly powerful, stable, research-grade applications, and you're able to make use of their ability to do skip functions, to do branching. You can do piped text to give reflection, so you can literally say, okay, so it sounds like you're not so sure what you want to do right now. You can attach videos and sound files and images so that based on their pattern of responses, you can take them to a screen that's designed just for them and has a particular video or image or sound file that's perfectly tailored just to their particular experience. So for example, these two screenshots here are from a really quick mobile web app that we made using Qualtrics, where we ask questions about substance use and particularly alcohol use in the past month. And we use that to drive them to a video that's tailored just for them. This is the work of a couple fantastic folks from my team, Lisa Todd and Samantha Jamblaski, who have really been able to do great things using this platform. Next slide, please. Second, there are website building tools out there, and I'm thinking especially of Squarespace and Wix. My team has preferred Wix compared to Squarespace, but they each change all the time and they both have pros and cons. They're really incredibly powerful in building very attractive, branching, easy to use websites that importantly use something called responsive web design. That means that they can automatically tailor themselves to the size of the screen that you're looking at. So if somebody opens it up from a great big desktop, they'll see one sort of format of the app. And if they open it from a tablet, they'll see another. And from a mobile device like a phone, they'll see yet another organization, but it will work beautifully on all of those. They have a lot of tools for data collection, although that's mostly metadata kind of stuff. So where the user was, what their IP address was, what sort of device they were using, what pages they visited. These are less strong in terms of getting survey data, although both of them have apps that you can integrate to work. And they both can do some pretty neat functions as well. So one thing to think about if you want to do a lot of heavy survey question and answer stuff before you launch into an intervention, you could connect these to Qualtrics or REDCap so that you can take advantage of their power for that survey function and then bring them to this for some sort of an interactive intervention. Next slide, please. And then third is something called the Computerized Intervention Authoring System, version 2.0. Now you'll recall that disclosure that I mentioned at the beginning, and you need to keep that in mind because this is the tool that I'm currently marketing. Couple things are happening though. One, we're moving away from it. Version 3.0 is going to be free for everybody. I currently have NIH support to build a greatly improved, updated version of this that will be open source and free to everybody. So we're going to be moving away from this version. The other thing is that I really want to see it be available for people who are finding themselves in a bind with COVID-19 and having to make adjustments to their research. So I didn't want to not talk about it, but I also didn't want to be doing anything that would be an obvious conflict of interest. So in consultation with Dr. Roach, basically the solution is from here on out for anybody affected by COVID-19, you can access this for free and I'll be as helpful as I possibly can in making you use it. So it's a really powerful program. It can do a lot. You can do interactive screening, assessment, intervention with it. You can import videos. You can do natural language reflections. It has an animated narrator who can speak in any one of about a dozen languages. It can send tailored text messages, so it does a lot. Two downsides. One, it's an authoring tool, so that means you would have to limit yourself to what it can do. There are only so many options you get with a tool like this. So rather than approaching it with kind of a blank slate, here's my idea, what I would like to do in an ideal world, you need to work within what it's capable of doing. And then secondly, it is not user-friendly. Every bit of funds I've gotten since I developed this have gone into adding new features. Working with it is a little bit of a bear. I would help anybody who wants to make use of it, but it is not nearly as user-friendly and simple as the new version is going to be. Next slide, please. So just in terms of quick practical considerations, and then I'll stop for questions. Next slide, please. Developing an electronic intervention is a little bit like making a slideshow in that you don't want to have too many words. People tend to come at it trying to replicate a person-delivered intervention, which of course is nothing but a lot of talking back and forth. It doesn't work that way. You want to think in terms of videos, images, not a lot of talking, not a lot of text. Don't want a screen that's full of text because your users will just disengage. I recommend plotting it out so that you have a map of what you're doing first, and make an outline first. Keep it really simple. Don't try to start making it perfect from the beginning. Have a broad outline, fill out that broad outline. Then once you like it, start filling in the details. And think about making it interactive and alive. You can have an app that is nothing but text on the screen. You can have an app that is from a character or from a person that says, I am interested in what you're saying. You can have an image. You can have the whole thing kind of be from something that's alive. Recommend giving that serious consideration. Next slide, please. Videos are incredibly powerful. They used to be really expensive as well. I would always have to work with a professional production company. Software like Powtoon and Beyond are very, very powerful, very inexpensive relatively, and you can do an awful lot with them. You don't have to have animated characters. You can have just images and pictures and scenes. They provide voices. They provide all kinds of neat features. You can build these inexpensively and then use it to enhance your interactive intervention. I highly recommend both of these. Next slide, please. Okay, I will stop there and open it up for questions, which I think are going to, we'll ask that you do those through the chat function. And I will read any questions over and hand them off to Jamie or Karen or myself as needed. Thank you very much.
Well, I'm sorry. Dr. Ondersma, to kick things off, I have a question. What about text messaging interventions?
Yeah, that's a great question. I didn't have time to touch on that much. Text messaging interventions are extremely common. They benefit from the fact that business uses these all the time. So that means there are many, many companies out there providing interactive two-way text messaging services at a pretty good price. I don't know anything about many of those companies. I use Twilio in the background for my software, so that's the one I know best. But another one called Mozio actually has the ability to integrate with RedCap. So I would seriously think about that. And I did get an estimate from them just as a sample to share with this group. The estimate for, and I just picked a 2-year study involving about 300 participants, and they quoted me about $6,000 with another $1,000 if I wanted to integrate with RedCap. So that's not too bad. They provide a lot of services for that money. There are a lot of great options if you want to go with text messaging rather than one of the other platforms that I described.
Thank you. For Dr. Ingersoll, Would you say a little bit about the benefits of an e-health intervention versus a mobile health app?
Sure, I'll tackle that, and Steve and Jamie may have some comments about that too. You know, they really have some different functions and features that should be considered when you're thinking about what kind of intervention do you need for your particular targeted group. So, for example, with Carrie, we wanted a really full-featured intervention that could mimic a very robust counseling platform that we previously tested. And so we chose to go with an because we could make it mimic that counseling experience in most ways, and that includes metering the content out in a theoretical or empirically supported way. We could provide guidance to the user on the order of the content. And that really stands in contrast to me for the way most people use mobile apps. Mobile apps tend to have much less, as Steve was saying, lots more video and pictures and things like that. So, but browsers of mobile apps tend to use them quite differently than full-featured e-health programs. They tend to use them sort of one feature at a time, or they use only a certain subset of features that an app might offer them. And so users navigate differently, and they don't tend to follow a particular browsing pattern. They can jump around and choose the features they want. So, you know, the utility of each program really depends on what you're trying to achieve in your intervention. And I've used both in my research, depending on what I'm focusing on.
Thank you. Dr. Ingersoll, could you give us an example of having encountered a serious and unexpected problem with online advertising and recruitment?
We actually are about to publish about fraud in an online internet intervention or e-health intervention for insomnia. And this was an intervention targeted at older adults. And unfortunately, we detected what we thought might be fraud relatively early. And we had advertised at a number of places, and the fraud was detected because we have a two-step enrollment process. One is that you submit an interest form, which screens for initial eligibility, but the second step is to actually have a phone conversation, as Jamie was recommending, with the potential applicant, in which we do more sensitive assessment. And in the process of the assessment, the one coordinator we had working at that time thought that she thought those voices sounded too similar to some previous participants she talked to. Long story short, we found out that we had a number of people who were trying to participate from the same families, from the same neighborhood, who weren't actually eligible. And so we had to put in some fraud protection strategies once we discovered that.
Well, thank you. Dr. Heffner, do you have a story to add to that?
A story. I would just say that this stuff is bound to happen. I guess one of the points that I hope to make is that fraud occurs offline as well as online. It's just easier to do bigger when people are online. So bots can, you can have 100 responses come in very rapidly. And if you don't have screening methods set up to stop, like if you have automated payments for people completing measures and you have a bot get in there and complete 100 surveys, you're going to be paying out a lot of money before you figure out what's going on. So setting up some hurdles in the process to slow things down and be able to go through and manually look for signs of fraud, I think is really important. And I do know people who that's happened to. It's not happened to me personally, but the bot taking up all the study budget was a problem.
Thank you. And one final question for Dr. Ondersma. What are some examples of the most successful e-interventions?
Yeah, so there are a lot of good examples. I think one of the things to look at if you want to see something that's really just working beautifully is Kathy Carroll's CBT for CBT. They've really done thorough investigation with this particular application in a lot of different settings, and it's always been connected to a little bit of human contact. And that's been very interesting to see. The literature on longer term interventions with and without some human contact there seem to suggest that they go better when there's some human contact. And CBT for CBT works just like that. And is getting really, really powerful effect sizes and consistent results, even in applied settings with relatively little counselor interaction. So that would be one that I would certainly highlight. Let's see. Another one that's been successful in a different way is something called Text for Baby. This is a program that's nothing but a very easy to enroll in text messaging program for pregnant women. And it's really as simple as going to a website, Text for Baby, or texting Text for Baby to a certain number. You answer a few questions and you're enrolled. There hasn't been a great deal of outcome data, although there have been some encouraging findings. But the neat thing about it is how many people are using it. It is just so simple and so easy to scale that it's getting out there in front of a lot of pregnant women in a way that most interventions never do. So those are a couple, I think, good examples on opposite ends of the scale. There are many, many other examples, but those are a couple that come to mind. I will say, Dr. Roach, that looks like we've had a couple of questions coming through the chat. I'm happy to stick around and answer them. I know that we're past an hour. Is it okay to do that, or Jonathan, do we have to sign off to make room for somebody else?
It's fine with me if it works for Dr. Roach.
It's fine with me.
Okay, fantastic. So this is a question that says, what translates best from person-to-person counseling to e-health? How do you make can you share any hacks to best simulate person-to-person counseling? Yeah, so I certainly can throw in a bit, but let me see what Jamie and Karen might think on that first, in terms of translating person-delivered interventions to e-interventions.
I have some thoughts on that. One thing that's made things easier when we've built an e-health intervention is having an already robustly tested and manualized counseling intervention. And it's not that you're going to ever, but that actually lays out for you so the specifications of what might be active in your intervention that you want to replicate in an e-health intervention. But remember, you're going to transform something that might be on a static page, even in a counselor's hand, to be able to take advantage of all the web delivery options that you have, all the interactivity, all the personalization, tailoring. So that's really just the first step, is to have a nicely manualized intervention.
I would add to that. I think, Steve, you referenced this, but having the appearance of a persona that goes along with the intervention. So you have a talking, it's a parrot, right, that's in there. So there's a persona of an animal that's kind of guiding people through. We've used avatars of people, which are hard to design, I've found, because it's just hard to come up with one avatar that everybody can identify with. So the tone, it can even be in a text messaging intervention, but if it's framed as if it's coming from a person, people are very responsive to that. So what people frequently say is missing from e-health or m-health interventions is support and accountability. And it's one of the top things that they appreciate about a relationship with a counselor. And so we try to sort of simulate that by having these social presence existing in these interventions. And so text messaging can be a natural way to do that, because people perceive that even if they know it's coming from an automated message bank, they'll send messages of thanks, like, thanks for thinking of me, and oh, that was really supportive. I feel like somebody's watching over me, just because that medium of communication evokes this image of a relationship, a face-to-face kind of relationship that you have with somebody that moves into the text world. So I think we can sort of build off of these things that we know help people about counseling relationships and try to put some of that into these interventions. And when we do put avatars in interventions, I'm thinking of a study we did most recently, people would say things like, oh, the avatar was really non-judgmental and empathic, and I'll miss this person. So there was some sort of projection of human qualities onto the avatar that they appreciated.
Yeah, I would agree with that completely, Jamie. And for anyone interested in just some fascinating research, I would refer you to the work of Clifford Nass and also Timothy Bickmore, doing research on what happens to interventions and what happens online when people interact with avatars, when you add a little lifelike component and all the attributes that they then give to that software when those things are present. And a lot of reason to think that that might add to efficacy and add to retention as well. In terms of other things translating, I think that anytime you feel the need to really communicate a lot of information, put it in a video. Don't just have words on screen. Don't even have your narrator say it out loud if you have an avatar or a character in your software. Put it in a video where you can incorporate images and highlight certain words on screen. It's a fantastic way to do that sort of getting everybody on the same page on something without having to kind of bore your poor participant to tears.
Are there other questions? Well, hearing none, Steve, are you seeing anything else?
No, that looks like it's it.
All righty then. Well, I then want to sincerely thank all of our panelists, Doctors Ondersma, Ingersoll, and Heffner, for an outstanding and empowering program. I know I personally feel reassured that the field is going to continue to advance and even to thrive through the age of COVID. We sincerely appreciate the support of our IT staff, Jonathan Folkers, Julie Simons, Tim Hedges, and Angie Healy. And to our audience, thank you so much for joining us. We wish you safety, good health, and peace. Goodbye now.
Bye. Thank you, everybody.
Bye-bye.
Bye-bye.